It is a joy to be with you guys. I was very involved. Should I stand in a certain area? Stand, sorry. This is also official, it's awesome. It is a real privilege. I was in CMDA my first year in medical school as well, but nothing as robust as what you guys have here. I am just so excited just to rub shoulders with Stan and Sophie and the rest of y'all. I came on as faculty about a year and a half ago for UT. I've been in academic medicine, missions medicine, charity cares. I mentioned this, if anybody has any interest, would love to connect with y'all. Charity care for Baylor, academics abroad. So that's kind of very varied background. But I've got to say, coming to UT was just awesome when I heard about SCF and connected initially remotely because everybody's on Zoom. But the more I connect with your group, the more I'm just super excited. And so you guys are in our prayers, my husband and I, our prayers, he's medical as well, on a regular basis. So you guys are on our weekly prayer calendar. So it is a total joy to be with you. I'm gonna kind of go through it kind of quick. Don't even worry about the slides. There's a few things that are on my heart. I had these slides from before and kind of mulled over it. And I felt actually the Lord gave me something a little different to emphasize, weirdly enough, from the slides. But I do want to go highlight a few things. A lot of references at the end. Y'all are referenced out, and you guys are all, full of slide decks and stuff. So don't worry so much about it. But if you want it, I have references at the end. I'm going to reference a few people that, if you're interested, I'm sure to some extent you all are because you're part of SCF, but spirituality and medicine. And I apologize about my mask. I hope y'all can hear me. So I have a special needs kid. So once he gets his booster in a week, God willing, I'm going to toss this mask really fast. So look forward to meeting you guys without my mask. So I just want to highlight a few things. Okay. So I want to highlight a few things. Understanding the link between spirituality and medicine. So when I was a first year in med school, I had no Christian mentors. Our CMDA was our anatomy professor. We had nobody clinical. So I went to school in New Orleans, very secular school. Not a lot of believers that I met rubbed shoulders in my 4 years there. But I sought out CMDA because I was like, I felt like the Lord called me to medicine. And I'm supposed to do something with it, but I kind of don't know how. So it wasn't until third year when I met a family medicine, not faculty, but a guy who would host like the dinners, like how you guys have it, you go to the community and some of the attendings host. So he hosted it, and his name was Mark Babo. And I just connected with him right away. And I was like, can I shadow you? Can I follow you? Can I go on missions with you? Because he was the only one in my 4 years. Isn't that weird? That I could tell identified as a Christian. He was kind of adjunct faculty, and he would come and do talks at lunch and stuff. But anyway, so that began my journey into, I want to bring the most important part of my life, which is Jesus Christ, my Lord, to my patients. But how do I do that, right? Like, it was just a huge disconnect. We're doing all this history, physical, assessment, and plan, and it's all good stuff, right? Healing comes from the Lord, right? All good things come from him. But how do I make that connection to my patients? And I remember my first rotation was in internal med, and one of my patients was a new cancer diagnosis, pancreatic cancer diagnosis. And I was like, oh, he's crying, his family's crying, he's hurting. The kids he's a slightly older 60-year-old guy. His family's crying, his kids are crying, and I'm like, oh, I want to ask him, does he believe in anybody? Does he have a faith? How do I ask those things? I don't know how to do this, I don't know what to do. And I remember I called Mark Babo, I'm like, there's a guy with cancer. Like, I remember he said, just ask him about his faith. And I said, how do you do that? Like, it was like kind of on the side on my lunch hour, it was really, so that began my journey into seeing how do we connect our faith to our patients, right? How do we find out where they are? So not so much that I have an agenda per se, except I know that what I have to offer in medicine is a big Band-Aid. It's a good Band-Aid, right? But everybody in the end of life has to face life and death, and also what comes after that. And also in this life is stinking hard. So I have Jesus, but how do I introduce him to my patients, right? If they need that, right? We all do, but if they're believers, how do I encourage them? When they're sick and they're ill. If they're not, how do I encourage them in that regard? Okay, so these are just some things. How are we comfortable taking a spiritual history? Do you guys, I know you guys have the colleges, and in the colleges, there's a little bit of the curriculum. Have y'all been through that? Has anybody had spiritual kind of exposure on how to take a spiritual history? Anybody, yeah or no? Awesome. So me, Tulane, big fat zero, never heard it. Nobody ever talked about it, right? So cool, you guys, I think if not now, I heard sometime down the road, it's somewhere in that curriculum. I actually called the GME office, I said, who does this? And they're like, oh, the colleges, oh, great. I talked to the head of the person doing college. I'm like, I'm just curious, what is this curriculum? And he says it's kind of built in. Some of it, there's a little bit of a curriculum, but then it's also kind of interpersonal with your college's mentor. So hopefully that comes. So how do I identify spiritual need in our patients, especially as it relates to their illness? They're here for a physical illness, right? Or mental illness. How do we make that, how do we identify what is their spiritual need in light of their medical need? And then how do we address it? So you ask stuff, then you got to address it. You do review systems, then something's positive, right? You got to do something with it. So I'm going to briefly a few things. I'm going to highlight a few names. You guys, if you are interested in the subject at all, I just came from a Duke amazing conference. This guy, Harold Koenig, if you search him, his CV is ridiculous. He is 70 years old, 70 this year. This guy has published 1,000 or more articles. His CV is ridiculous. It's like 60, 80 pages long. He actually gave it to me. He's like, somebody wanted it. He's like, all right. And then I was like, this document is taking forever to load. I read this guy as a resident, and I knew some of his work. Ridiculous. He is the ultimate pioneer in this regard. He's a family medicine physician by training, then did a psych, back then they did a psych fellowship. He's actually practicing psychiatrist at Duke, full professor at Duke, the #1 published physician in the world in terms of spirituality, religion, and health. He has this book, it's almost out. So it's Koenig and Vanderweel and Petit. So the co-authors change. He is always author. This is the 3rd edition. It's coming out soon on Amazon. I can't wait. I have the older edition, but the newer edition has more information. But on this, he goes into the clinical science of outcomes for those with religious background. And by religion, I feel like there's it has some negative connotations for some folks, right? Seems restrictive, seems legalistic for some, not all. But in the research, the term religion is separated from spirituality. And that spirituality is kind of all-encompassing, includes religion. But it could be just kind of, there's a little bit of even emotional and social aspect tied in with what we think of as spiritual aspect. So it's kind of a more general term. But religion, by definition in the medical literature, tends to be a standard practice of your faith in a faith community with regularity. Okay, and so that's why there's this term spirituality and religion in medicine. And so he publishes on spirituality and religion in medicine. Strong believer, he's spoken for CMDA, and he's just super awesome. If you guys down the road, as you are thinking about research, and you guys have that in med school and in residency, check this out. 1 week thing blew my mind. It was one of the best weeks I've ever spent. So on how he does research in this area, there are a lot of people publishing, but how to do excellent clinical research if you're interested. And then a spin-off of that, that's quantitative research. There's qualitative research in this area. And there are a lot of people that brush shoulders for his weekly thing out at Duke, always in August. So they're gonna have the 19th, I went to the 18th session. They're gonna have the 19th session this August and every year thereafter. So good use of CME monies when you guys are residents and needing to do research. So he is pretty awesome. Another guy you guys should, his name was in the back of my head. I didn't really know what he did. As I read more on him, this guy, Tyler Vanderweel, biostatistics, epidemiologist, PhD, very well renowned in the world of statistics. So he co-authored, you probably saw the co-author, the book up there. Sorry, it's kind of small. But, so that book I was gonna reference is the handbook of all the clinical, qualitative and quantitative, mainly quantitative research in this area. So they both are super ridiculously referenced, like in the tens of thousands of citations if you were to search these guys. Crazy well-known in their fields, okay? So strong believers. Tyler Vanderweel just got an NIH grant of like close to $1 billion. $1 billion. Okay, for international research in this new term called flourishing. So you look at what his definition of flourishing is pretty awesome, right? Happiness and life satisfaction, mental and physical health. That's nice. Meaning and purpose. Okay, tuck that away. Character and virtue, tuck that away. Close social relationships, financial and material stability. So this guy so includes a lot of other American researchers, but he's doing international research in the topic of flourishing. Sounds super fun. They're very well respected in this world. Another guy I want you guys to be aware of, he's in his 70s. Anybody heard of Walt Livermore? He used to be on Focus on the Family. Probably if your parents listen to Christian radio or, this Focus on the Family is like, a lot of psychologists, Dr. James Dobson, now there's a new psychologist running it, but Walt Livermore is probably the most widely recognized Christian family physician in the United States. I think his number has gone up. Since I made the slide, I think he published like 5 more books. So he turns out a book a year, 2 books a year. But writes a lot of articles. He has a great website. And I use that in my Epic after visit summary, like for patients for health, things. I kind of point them to his stuff because he talks about the highly functional teen, highly healthy so-and-so. And they're all based on biblical Christian principles, right? And it's always a good point of contact, like for me to follow up with patients. So anyway, this guy's well-published. He's a mentor of mine, adjunct faculty in my residency. I forgot to mention, I went to In His Image Christian Family Medicine residency up in Tulsa. But so I brushed shoulders with him initially, and I just approached him. I said, I just want to know you for the rest of my life. Can I? And so, but anyway, I mentioned him because a lot of the slide deck comes directly. He summarized a lot of Koenig and a lot of the other guys in some of his work. So he's published for CMDA. He has a couple articles in the magazines and stuff, and he's a circuit speaker for CMDA as well. So if you guys want to know more in this, I just mentioned these guys. His website's drwalt.com. Okay. So Gallup poll in 2016, and they've done this again, but this is just a pretty slide I was able to pull from his stuff. So how many people in the United States believe in God? 89% will say we believe in a God. How many people think that religion is important in their daily lives? 75% say that. All right, this is just general population, okay, across the board. What do patients think? So Gallup poll says, how many people actually say they use prayer for healing? If they're sick, they might pray. 1 out of 4 people use faith to cope with illness in some way. 40%. Spiritual health is as important as physical health. So remember those things that I just came back to? How the meaning was? Meaning and purpose. So a lot of people, they tie that in with meaning and purpose, right? How many people feel meaning and purpose is as important as their physical health? They want physicians to address their spiritual needs. 90% of people, this is 2016, but 90% of people polled prior to pandemic. I want to see the data after pandemic. Okay, many studies show that patients especially want physicians to address their spiritual need during time of stress. Lots of stress going on these days. Inpatient admissions, life-threatening cases, right? And end-of-life care. And I have references, I put little tiny references at the bottom, but if you guys wanted a big laundry list of references at the end of this, if you want to kind of look this up. But what do physicians think? So that's interesting, right? That's what patients think. So that red bar is how many people actually want us as physicians to address this? The want is there, okay? But how many of us as physicians, 2016, believe that religious beliefs can help heal? 99%, whoa. Believe others' prayers can promote healing. If someone else prays for me, might actually help me heal. 75%, it's a good majority. Feel physicians should be aware of patients' needs. 85% of us think that we should kind of know. How many of us have inquired about a patient's need? 9%. These are honest people doing the survey, right? I feel like I should know about it. And this is exactly how I felt at the beginning of med school and almost near the end of med school, okay? Okay, a little bit of kind of people who keep things going. JCAHO, the Joint Commission. So this is JCAHO, what they do is they go and they make sure our hospitals are safe, okay? And to some extent our clinics are safe. So they go through and every 3 to 5 years, depending on how good your institution is, they come and they basically recertify an institution. And if you don't meet par, you got to do some follow-up things and they revisit you again until your facility is considered acceptable. So they said that certification, you need the certification for any hospital system that is accepting Medicare or Medicaid. What hospital doesn't, right? So basically every hospital submits themselves to JCAHO inspection, right? In 2001, they made a statement. They said that we need to do a spiritual assessment of patients in hospitals, in nursing homes, and those receiving home health care, because they're paying for this, right? In 2008, they came up with some updates, and they said that, that's super tiny, but basically they're saying that we need to assess a patient's perceptions and their spiritual values, because it does pertain to their care, it does affect their health, right? So they're looking at it from a health standpoint. We have to have pastoral and other spiritual services for patients, okay? And then it actually has a category C in terms of element performance, for them to be able to measure success. So I failed to mention, Harold Koenig, when he published, his stuff is largely used and even referenced by JCAHO because if we actually promote spiritual care for our patients, we decrease their length of stay. Very good data on that. across almost all metrics, from post-cabbage, length of stay, morbidity, mortality, post-MI, post-stroke, depression, anxiety, some of those make sense. But even like immunosuppression, a lot of clinical metrics are much improved, both in terms of rate of mortality and morbidity, okay? So I forgot to mention that. So Jacob says, hey, we know if we address spiritual care for our patients, we're gonna improve outcome, okay? To the point that they said, you need to assess this, you need to provide care, okay? And a lot of stuff was being provided, largely through chaplaincy, I'll mention that a little bit later. But they're saying, hey, now we need to make it a point that we do an assessment of every patient coming in the doors. Wow, okay, that's a lot, right? And then there's a category B, they have a category B performance metric that they said that if we assess their, and they said specifically for patients receiving end-of-life care, there's spiritual elements we need to address for them, okay? All right, so there's 7 standards outlining where spiritual assessment and professional response were required. Substance abuse, psych disorders. We need to learn about spiritual sensitivity in our patient education, how it affects barriers to care, even our food preparation, because some people have food needs, specific food needs. And we should all be doing this, addressing death, dignity, dignity, patient's dignity in death, in grief, and comfort in the end-of-life care. And this is credentialing criteria. So they have certain criteria for them to meet. All right, so now we know we're supposed to do it. So remember that 9% of physicians say that they've ever addressed spiritual concerns or spiritual history for patients. Why are not more of us doing this? Right? So lack of time. Some people say, hey, if I do it in a clinic visit, what if they tell me? Now I've got to address their COPD and their diabetes and their diabetic foot. How am I going to do this, right? Sometimes I just experience. I was one of them. I don't have anybody doing this. No one ever modeled this for me. How do I ask them? Be like, you got a religion? That seems kind of awkward, right, to ask. So difficulty in identifying patients who want to discuss spiritual needs. We know end of life they probably do, but do they really? Is it kind of sensitive right now for me to talk about it? Or what if they're here for their well woman or their well person? If I'm a family physician, do I address it now? Do they want to talk to me about it? I don't know. We have a lot of hemming and hawing going on. I want to, but how? Especially as believers, as Christians, right? It's such a big part of who I am. I'm not just a physician. I am foundationally a child of God, given, the Great Commission, right? So how do I do that? So this is stuff I wrestle with, so I can identify with all this. So I already mentioned better outcomes. I'm going to say this. This is me 15 years into practice, and I'm still practicing. I love the word practice in medicine. I'm always practicing, right? But 15 years into it, I can tell you, just from a personal perspective, every patient I've done a spiritual assessment who has connected with me in that way or wanted to, I tell you what, it's life-giving to me to know whatever their faith background is, be it if they're believers, if they're not, knowing that part of them is another aspect of them. And it is really fulfilling. And I'll get into more about that in a little bit. Okay, it broadens the patient-physician relationship. It actually increases effectiveness, and there's data to show that. I have many references down there, but it increases our rapport with our patients. They feel like, hey, she or he, they want to know me. This physician isn't, especially if you get a primary care. Even if you're a specialist, if you guys are thinking of specialty medicine, right? You have that moment in time, a very captive audience, a moment in time where they're there for you with a very specific need. You think, well, I'm just here to address their lung or their kidney, or I'm an ER doc and I'm here for this emergency. Is it really my role? So I challenge you to think about that as you guys go through your training and say, where is my niche in this part of spiritual history taking? We are not the end all. We are not the Lord. Only the Lord is the Lord, right? So, but we are one piece in someone's, hopefully, maybe encouraging them in their faith journey, right? Even as they're coming to us for care. So I would just say it broadens our patient-physician relationship. It makes them more receptive to the things that we ask them to do, some of which are really hard, okay? It improves their compliance. So there's some data on that. It helps us to recognize their spiritual or their emotional challenges affecting their physical health. And a lot of it does interact or intersect. Okay, and it helps us to guide them into ways for them to heal and to cope. There's a lot of very tangible things. Okay, kind of went into that. I'm gonna skip this because our time is short. Okay, so I stole this, and I gave a reference on it. I adapted it. I added another petal to this flower. It was kind of a Venn diagram. So you guys tired of Venn diagrams? There used to be a ton of Venn diagrams when I was in med school. So I kind of hated Venn diagrams until I came across this. So aspects of wellness, right? So we are whole people, right? We are physical people, we're mental people, we're social people, we're emotional people. And a lot of our medical training leaves out the spirituality. I kind of like, if you can picture it, I just couldn't really do this I'm not that artsy. But if you can actually take spiritual and put it all the way around, instead of just as a pedal, if you took it and you kind of just put it all around, all these other aspects, right? There's spiritual elements in all these areas of wellness, okay, and intersect. Bear with me, very busy slide. Don't get too bogged down in this one. I'm gonna actually, for sake of time, I was gonna ask you all, what are biological? You guys are the biological, mental, we talk about emotional, social. There's a bit of training in med schools about these, right? What are things that offer us support in these areas, right? And we promote a lot of, obviously, the biological, the mental, even emotional. We encourage people to be social, right? We don't tend to spend as much on the right side of this thing. And there's an element of spiritual. So people's ethics affect their health, their wellness, people's moral beliefs, their purpose in life, their sense of peace, and finding a source of peace. These are spiritual elements, right? So, busy slide, I'm gonna skip that a bit. Spirituality is much like other parts of wellness. It touches every part of our lives, right? So example, what's the definition of ethics? One is principles that we have that govern our behavior. I'm gonna go through this lightning speed fast. I know you guys know a lot of this or all of this already, but morals are a sense of what's right and what's wrong. What is okay, what is not okay? What is intrinsically right, what is intrinsically wrong? Our beliefs is how we see the purpose and the structure of the world around us, right? How we perceive the purposes and the structures of the world. Our purpose, this is really interesting. Why are we here? What's my contribution to my environment, to my world, to my area of influence? Where do we derive our sense of self-worth? Okay? These are purpose questions. Peace is a sense of well-being. Sometimes in spite of negative or suboptimal other aspects of life. So when we're sick, that's kind of suboptimal, right? Fundamentally, there's a peace. The thing that fights with peace is fear. Who's in control? If I am not in control, and I'm not, who is? Okay, what comes after death? A lot of the what ifs. So this kind of falls under, and can disrupt a person's sense of peace if they think too much about it, right? Or if they think about it. So all these are spiritual aspects of wellness. So how do you do a spiritual assessment? A caution before we actually go into that. And so there's a guy, Stephen Post was a board member of very cool, if you guys ever do research in this area, the kind of ultimate supplier of funds for this, besides NIH, you have to do this, I think, very, very strategically and well to get NIH funding for this, like Tyler Vanderbilt, but the Templeton Foundation, I just throw that out there, just in the back of your mind, if you ever do anything that touches in the realms of spirituality and medicine, they fund millions of dollars every year for this kind of research, okay? So the founder's a cool guy, now deceased, but a businessman who earned a lot of money, and he wanted to promote research in this area decades ago. So one of his board members in the past, Stephen Post, said, we just have to be careful. We don't want to faith push, right? Even as believers, we don't want to faith push. We want to do this in a very sensitive way. And I think we can as believers. We can do this in a very sensitive way. So we want to be able, instead of ignoring it, just because this is actually a little hard sometimes, or it could be a little challenging. I feel like as I speak to you guys as believers we have the Holy Spirit. The Holy Spirit is a gentle Holy Spirit, right? So whatever we do it with gentleness, with kindness, with love. And as we ask him for wisdom, we can do this, okay? So he's a believer, but he kind of cautions us, like we gotta be a little careful with this, okay? So the goal of the assessment, what do we gain when we take a spiritual history? What do we want to know? Understanding, right, just of their background, what the role is in terms of their disease. Like, can some of their faith practices be helpful? Can it be harmful? Beliefs that may influence or conflict with our decisions. We may suggest certain things that may conflict with their faith background. Patients' level of participation in their community, whether the community is supportive. So there's a direct correlation with those. Interesting that I mentioned this. So a lot of the research is on monotheistic faith backgrounds. Judeo-Christian, include some Muslim faiths. I was talking to Kane at this conference, and I said, when you research them, it seems like you lump a lot of people together. He goes, yeah, it's just, in the US, we're a diverse culture. In order to get a large sampling size, he has to cluster people, right? But very interesting thing. So spirituality without religion, remember I said spirituality can include religion in the literature? It's kind of a little bit of a muddle. But if you look at studies that show that specifically use a cohort of spiritual people without religious practice, without a common community, without standard faith practices, prayer, attending faith services, having small groups, that kind of thing, right? They actually have worse outcomes, clinical outcomes, than atheists, than those with monotheistic faith background. So that's shown in literature. But the point of this is to say, for those that do participate in a faith community, in a community of faith and with religious practice, how does that support them? And can we support them in that? Okay, so that's one thing. And then helps us just to keep that in mind first. Okay, you can do this. This just reminds me. You can do this in 1 minute or less. Inpatient or outpatient, 1 minute. We do a lot of other stuff in our admit hour. So our goal, at least in family medicine inpatient, is for a resident to admit a patient, do the orders, do the note within 1 hour. Okay, the end of first year, as a first year resident, that is our goal. We send you down for the mission, you go to the ER, be able to take a history, at least do the orders, spend some time wrapping up your note, be done in an hour. Now, beginning, it's 4 hours. When we first started, it's like 3 to 4 hours running mission. But at the end of first year, at least into second year, they'll be able to do that, right? So in the laundry list of things that we have to do, and Epic is ridiculous. Epic's awesome, but Epic's ridiculous. All the clicks that you are gonna have to do. How do you do this? Sorry. Okay, I want to. This is actually from Walt Larimore. Very busy slide, but I'm just gonna say, his mnemonic, and there's other mnemonics out there. So AAFP, American Academy of Family Practice, published a few articles on this. They highlight something called a FICA, F-I-C-A, and a HOPE score. You guys can look that up. I didn't include it in this one. This one's specifically from CMDA from Walt Larimore. So if you kind of remember GOD, God short, right? May I ask you about your faith background? Or do you have a spiritual or faith preference? Is God's spirituality, religion, or spiritual faith, that's a mouthful, important to you now or has it been in the past? It's gonna take more than a minute to ask and do this. So I read these as questions that are options for you, okay? And I'm gonna show you in the next slide what I do. Others, so G and then O, do you meet with others in a religious or spiritual community? Have you in the past? If so, how often? How do you integrate your faith, how do you integrate with your faith community? The D, the do. What can I do to assist you in incorporating your spiritual faith to your medical care? Is there anything I can encourage you in your faith? Okay. May I pray with you? May I pray for you? Right? That's a lot. I can't do that in a minute. These are just options, right? So I came up with this sheet. I don't ask this. When I see a patient and they're new, and my UT Southwestern has a standard stack of papers that they have to sign. They have to sign like their life away. There's like 5 or 8 sheets that they have to sign when they come in, right? They can do it online. They have the regular medical, physical inventory that you take, all their meds, all their allergies, blah, blah, blah. They can fill it out online ahead of time, or they can fill it out on paper when they come in. So I just instruct staff working with me the day that I'm in clinic, like, hey, slip in this sheet too. You'll get me out of the room faster. First they're like, oh, should we? I'm like, please, I'm gonna be asking you, might as well slip in the sheet. It's like your PHQ, your depression screen, your whatever, your anxiety screen. I'm like, just put it in there, right? And the cool thing is, people love filling this out. I get novels sometimes if I'm late, and they're just filling this thing out. They're like, wait, hold on, let me just finish this real quick. I'm like, okay, you can keep it, and they're like, no, this is really good, and then some people are just like, NA, that's fine too, right? Then I know for them, they're not ready for me to address that. And sometimes you'll get people who are Christians that write a bunch, people just write, you may pray with me if you are a born-again Christian. I'm like, okay, cool, that's cool. Or depends on your faith background, doc, is really cool, right? So you kind of know where they're from, like where they're coming from. Even, those who might be more cultural in their faith, those that really are practicing their faith, this sheet really helps me a lot. So I kind of pulled this a little bit from FICA, a little bit from Walt Larimore, a little bit, and I've been using this for probably the last 10 years. Inpatient, okay? I don't do all of that, but I'll pick from some of that. And I get to see them every day. When they're admitted 5 or 6 days, guess what? I ask you a little bit of this every day. In EPIC, what I do is under social history, there's a social determinants of health. Once you guys how many of you are third years now? Mostly second years, right? And you guys are starting your clinicals already soon. So as you guys get into EPIC, there's this button, and there's SDH, and there's all this wheel, and you gotta click 5 times to get into the spiritual history section, and then there's like this one little box that gives you this much room. Well, I do that when I can, but I open up the box that gives you like hundreds of words. And I'll just put my one-liner, right? Christian faith background, appreciates prayer, attends St. Andrew's Church, blah, 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 and all that, right? I write some of that free text. And in my template, I actually pull the social history into my note. So when I see them, I click a button. If anything I've ever written or anybody else has written in that box will show up in my history, right? That'll be in the forefront of my mind to know where they were before. Kind of like, what was your blood pressure the last time you were here? Where were you socially? Had good conversation about, and I'll use the yellow, you guys will see there's a yellow sticky that only is you. No one else will see it, it won't make it no. I use those for like, hey, pray with the patient, he really loved it. Remember to pray with him about his whatever. I'll do that, right? This is part of my spiritual care. So if they say, would you like your physician to pray with you? I don't want to ask him not to do it. Side note, okay? But this has been really helpful for me. I interviewed Reverend Renty was in a past practice of mine with Methodists. Reverend Renty, I sat down with him. He was the head of chaplaincy. And I just asked him, I said, I can tell people, I kind of know what y'all do. What is it that you feel you offer? He's a believer. Caesar Renty used to play for the Chicago Bears, really cool guy. He said, I just really realize patients are afraid when they come in, especially when they're admitted. Everybody's afraid. I've been admitted, I've been afraid. My kid gets admitted all the time. Every time he goes, I'm a little nervous, right? He goes, fear is a spiritual issue. So I try to help them in grappling with their fear. And I was like, whoa, that's deep, okay? So if a patient, this is his thing, he says, when they express their fears, his key thing that he wants to tap into is, what are your fears? How does your faith play into your concerns? How does this medical diagnosis, concern, and your faith affect your future? How do you perceive this affecting your future? These are some standard questions he asked. I was like, can I come up with that? Yeah. So he let me do that. And I said I would share this in the future when I was able to present on this. One easy thing, and what everybody is challenged to do, and Jaco asks us to do, very easy. I just bring up chaplain every time they come in. Like when I can, I'm like, hey, at the end of my first visit with a patient, inpatient, especially inpatient, I'll say, hey, we have a group. They do pastoral care. Is it, now, interesting enough, most in chaplaincy have a Christian faith background, but not all, right? So I talked to the director of Parkland when I first came on. I'm like, hey, give me a feel for your chaplaincy. And they, like many hospitals, I'm gonna mention a few things that they do, and I'm gonna mention some of the programs that are there. So what they say is they want to try to connect them to their faith community. They can actually do referrals. So patients, I say, I'm Catholic. Yeah, I used to go to church, but it's been a while. You hear people say this a lot. I probably should, right? People feel their own need, especially in times of crises, right? I probably should. And you're like, oh, well, hey, could I help you in this regard, right? Chaplains do that a lot. They connect them with our local communities of faith. They encourage patients' reconciliation in their lives. So people that have unreconciled issues in their lives actually have worse outcomes, so they do that. They sit there and they're with the patient, okay? They also do, the thing that they get most consulted for are end-of-life stuff, like power of attorney, medical power of attorney, not necessarily end-of-life stuff, but medical power of attorney, advanced directives. If you're gonna be coded, are you a full code, are you not? We tend to go knee-jerk, chaplain, right? I like to write a few words when I do that referral. Patient has spiritual struggle. Is a Christian, but wondering, is God good? Whoa, I may not have the time right now. I got 12 more patients on my list around on this morning, right? But I'll write that for the chaplain. They're like, whoa, okay, good. That helps them, right? I'm not just here to do your medical power of attorney, but I'm actually here to, there's a deeper need. Hey, the doctor told me that whatever. When possible, I usually try to make a quick phone call to them. Hey, I want to do a warm handoff to you when I can, okay? So you guys as residents later, they welcome that. I'm going to skip this a little bit. I'm just going to say there are chaplains of various faith backgrounds because many people, Muslim faith, Jewish faith, Hindu faith, a lot of them realize people in their faith communities have needs too, right? And they want to go into this. Chaplains are not trained to proselytize, but they are trained to walk with people in their faith journey. Now that being said, most chaplains and most hospitals that I've been in here in the DFW area, most of them are of Christian faith background. Not all, but most. What I do is if I find the patient is evangelical, patient is of Catholic faith background, is of Jewish faith background, if they specifically request it, I'll mention it. But if not, I will say, hey, chaplain, and I'll put it in my thing. Patient is of this faith background. They will try to match. I asked Parkland. They say, yeah, we'll try to match, if they're available, because we feel like they can better serve this patient population, right? But if not, the cool thing is by default, okay? Most of our Christian faith background. So they actually do pastoral training. Chaplaincy training. There's actually a program that Parkland does, and most hospitals, not all, but most academic hospitals will be doing. So a lot of people will come and actually do a year of what they call residency for a year in order to be certified as a chaplain down the road. Okay. Okay. We kind of talked about this a lot already. I'm going to skip that. I want to highlight this for you guys as providers. This is a side note. One of the things that is hard in medicine is we see a lot of craziness. And we are the providers, we are the physicians, right? We are there to serve our patients. We're going to see a lot of hard stuff. I think accessing chaplaincy for yourselves is really cool. In your faith community, your church or faith community, fellowship with others. You guys are here already. Like fellowship with others who are in the same boat, right? Clinicians who are physicians. Awesome fellowship. Stay in that for the rest of your lives, guys. I just really encourage you. I'm preaching the choir, but CMDA is awesome. CMDA champions a ton of stuff for us as physicians of faith. Stay involved with CMDA or the like in your community. Many times physicians can be like the lone physician in a small church or, one of a few, and then just, we face things that are very different than those in other professions, right? So stay in fellowship. I just encourage you that. Chaplains are awesome. They debrief us sometimes. Caesar Renty, I told you it was my past job was at Methodist. He and I would eat lunch like once a month. He'd just come up. I'm like, when you're here, I want to eat lunch with you. And he'd like text me, go and be up at Richardson and the next, this week. I'm like, eat lunch with me. Like just having, I think, people to hear us and some of our concerns. So big proponent of counseling as well, but that's a side note. Just kind of keep that in mind. Chaplains are for our patients. They're also for us. Part of their role, they're trained to be chaplains for us. Okay, I already mentioned what I do in Epic. And referral, when you guys start in most hospital systems, especially those using Epic, it's a referral thing that you can do, okay? The objectives, we kind of went through it real fast, but the link between spiritual care and healthcare, we touched on that. Hopefully feeling a little bit more comfortable taking a spiritual history. You develop your own style, develop your own style, try different things, try different questions that you can ask, right? So I used to say, I always felt kind of weird saying religion. So I'll start out with, do you have a spiritual, it's always really funny, so some people get it, some people don't. Do you have a spiritual background that you want us to know of as it pertains to your healthcare? People are like, spirit what? They just weren't expecting a question. I'm like, spirituality, they're like a religion. It's so funny, about 80-90% of the time people are like, you ask me my religion? I'm like, yeah. So for me, the barrier of saying religion actually kind of, wore off over the years. I felt it more than patients really feel it, okay? So like, oh yeah, I'm Baptist, yeah, I go to, or yeah, I'm kind of non-denominational. Or some people say, I'm spiritual. And I'll say, well, what do you mean, right? So have fun with it, okay? So the more you practice anything, the more you get good at it. And if you're awkward, I was super awkward, super awkward. Patients are so gracious. They still came back to see me. Oh my gosh, that was awkward, but you came back. And again, you came back, oh good. And they'll say, hey, after you have that relationship with patients, and especially so caution, if you've ever prayed with a patient, and they appreciate it. Of any faith background, I hardly get turned down from prayer. So usually if patients have, some patients of very faith backgrounds are like, yeah, I appreciate prayer. I'll make it a point to pray with them. And more often than not, even if they're not a Christian faith background, they'll say, that was beautiful. Wow, no one's ever done that with me before. I'm like, wow. And I'll say, that was a real privilege. They're like, okay. And the next time they come, if I forget, they'll say, you prayed with me last time? Are you going to do that again? I'm like, cool. So the more you experience that, you'll realize patients really, and some will say no, they're no. No, okay, yeah, they're totally fine. I just offered to all my patients, it's all good. Or, as you feel led. Some don't necessarily pray with all patients, totally okay. The Holy Spirit leads us into things to do, things not to do. There are times I just feel like, God's like, that's not the time. Don't go to that. You got to address this really critical thing. If you don't do that, they have no ears to hear you if you're not addressing their felt need, right? So, and so keeping that in mind, that spiritual care for a patient is part of whole person care, right? And for those that are going into specialty medicine, if they're there, if you're an ENT, they're there for your ear, right? You're like, how can I do it? You can ask some of the similar questions, and especially if you're in a system like UT, and we all share the same EMR. That's really cool. You just added another puzzle piece for this patient, kind of like we use the problem list. You'll see that when you guys delve into Epic. You guys will be one of the ones that will update the problem list, okay? And you'll just update that, right? So we get a whole picture of this patient as they come into us, maybe for an ear, maybe for a lung, maybe for their wellness, right? We can work together as a team in that, and that's really cool, especially as a faith community in medicine. I love seeing that. Sometimes I'll see some stuff in the chart. I'm like, ooh, and you'll see who the last person was that touched it. I'm like, Dr. So-and-so in OB, yes. Like, really cool, And so anyway, so I leave you with that. I just want to say, if you guys if you guys ever, if I could be of service to you in any way, actually my practice name is Liu, L-I-U. My email is Kwok, because I'm married. My legal name is Kwok, Christine.Kwok at UT Southwestern. My cell phone's up there.